All right. So has everybody got neurodevelopmental behavior, mental health disorders pulled up? We're going to take a different spin and we're going to move from some of our neuro stuff. Now this is neurodevelopmental, but we're taking a whole new different path. Now, Dr. Blankenship, can we get, I got so much on this screen besides my PowerPoint. Can we get rid of some of that? Not this over here, but that across, it popped up. That thing right there just popped up. I have no idea.
Well, I don't know if we can. Let's see if we can get it dragged down. How about that?
Okay.
Is that better?
That helps.
Let me see if I can.
The screen
hide
sharing
it.
is paused. We're not sharing.
Seems sure.
I want that one gone.
You want this PowerPoint going?
Yeah. Okay.
Oops.
Don't
Let's
you
go
just love
back.
technology?
Are you guys seeing assessment for mental health for daily use? Is that what you guys got? Thank
Okay.
you. There you go.
Okay.
Is that where you were?
Yep.
Okay.
Yep. Okay. All right. So part of every day, any kid that comes in, especially your older kids, your adolescents, your middle schoolers, if they're coming in for a well child, especially, this is, you're going to be assessing for mental health. And this is a really nice, quick HEADSS, HEDS, or HEAD-SS is great because you can, while you're listening to their lungs or you're looking in their ears, you can talk about all these things, their home, family, education, employment, all that wonderful stuff. Are they doing any outside activities? Have you got any friends who are doing any drugs or substances? Have you ever tried any of that? Are you sexually active? How, are you using protection? Are you having any issues with suicide or suicidal tendencies? Are you depressed? Do you feel like hurting yourself? That is a really quick mental health assessment that you can do, that anybody can do, just as part of your normal visit time. So as we talk about that, we're going to talk about some of the most common things, and these are for adults as well. So we're going to start with anxiety. Believe it or not, we have a significant amount of issues with anxiety in kids. Now there's multiple, it's very diffuse apprehension in response to a very less specific stimuli. We have all types of anxiety disorders. There is this wonderful tool that will help us. And we're going to talk about that. We talk about anxiety in kids from these 4 basic different types: separation anxiety, generalized anxiety disorder, OCD, and post-traumatic stress disorder. And then there's, so these kids are usually impaired social functioning. And a lot of times these kids also have parents with an anxiety or mood disorder. And you will see them. They're the ones who want to sit in the corner. They will chew on their finger or chew on their nail, or they'll have their head down. They won't let go of a parent. They get all kinds of issues. Now, this is the DSM-5 definition, and I could not find it in this chapter, in this edition of the textbook. But this helps us define it. So read through this and kind of get to know it. Look at some of the symptoms. The worry or anxiety or worry are associated with 3 or more of the 6 symptoms, more days than not, greater than or equal to 6 months. So restless, easily fatigued, muscle tension, irritability, poor concentration, and sleep disturbances. Significant issues with concentration and sleep disturbances and irritability. Some of your physical signs and symptoms can be that. Sometimes some of the things that end up being anxiety can be mistaken for ADHD kinds of things, or heart pain and chest pressure. We've got a lot of kids that we've worked up for chest pain that were having palpitations and and being short of air and hyperventilating, and just had to do with anxiety. And sometimes it is chronic anxiety, and sometimes it's just an acute anxiety issue. So it really, you kind of have to look at different things. You've got cognitive signs and symptoms and behavioral signs and symptoms. And I'm not going to insult your intelligence on looking at that, but we've already talked about some of those. The cognitive signs and symptoms are, they're always what ifing. What if? They're always worry about things. They're constant worriers and concerns. They look at the big threats, the people that won't leave their homes, or the kids that don't want to go back to school now because they're scared to death they're going to get COVID or they're going to die or something else is going on. So, and then of course the behavioral. So some of those screening tools that we use, if we've got a kid that's coming in that we know is that mom or parent has identified as having some anxiety issues that they want to talk about, or if we get in a room and something else triggers us to think that anxiety might be an issue, we're going to use a screening tool. We just can't say, oh, they're just anxious and we're going to do something about it. So now it's going to be, you're going to see a couple of different things. So because I use different references, so some of the things are going to come from your Burns book, and that's what you're going to be tested on. So be very careful, okay? And then some of the things come from the American Academy of Pediatrics. So I've tried to identify what comes from where, okay? So Burns book talks about the Spielberg State Trait Anxiety Inventory for Children. I've never used that. I've been told it's a really nice anxiety screening tool, but if you see the double asterisks, the screen for child anxiety related disorders, it actually has a broader range of kids that we can assess for, whereas the Spielberger is only 9 to 12. The SCARED is for 8 to 17. So that kind of gets your third graders through your seniors in high school. Okay. So SCARED, and that's what I'm going to talk about. Okay. SCARED is, there's both a child version and a parent version. And there's it's 41 item self-report, rates from 0 to 3. And if they have over a 25, it may indicate a presence of an anxiety disorder. And the interesting thing is, it will tally at the end, and it will tally for separation anxiety, social anxiety, school avoidance, generalized anxiety disorder. So, and you can determine if they are having more issues with one than they are another, and where you need to focus your intervention. So I love the screening tool. Now, I had a younger kid come in recently that mom just felt like there was significant issues with anxiety. Well, she was younger than 8. She was like 5. Well, she can't read it. She probably can't understand it. But I had the parent to do the parent version for this kid, and it was significant. And so we were able to use that as my diagnostic criteria for treating this child for anxiety. 5-year-old now, 5-year-old with anxiety issues, significant enough to cause social issues. Okay. Now there is another scale on the next slide. That's the GAD. There's a GAD 7 and a GAD 2, and that is, Mernick is spelled incorrectly. It's Melnick, MELNYK instead of Mernick. And I'll edit that. I didn't have the book with me because I keep this book at work with me all the time. And that's where I found the GAD 7 and 2. They had that in their inventory of stuff that they can look at. Yes. Excellent. Okay. They have several different. Good. Now, this is not in your Burns book. This is what I pulled from, and when I put my stuff together originally for this, from what I was studying for my pediatric mental health specialist. So, but the GAD is very good, and there's the 2-question GAD and the 7-question GAD. Now, that is great if you want to use that as part of a routine screening. There is a complete screening toolkit online. That's called I can't remember it, almost brought it with me today. And it's got a ton of information, much more than your textbook has and what we're going to than anything else. And that was part of what I had to study for my certification. And there's just so much there, and it really talks a whole lot about anxiety. Yeah, you
There
could.
is a document that is in here that is labeled as childhood autism spectrum test, and it has the scared in it. It has lots of
Okay.
different things in it, but it's all together. I'm gonna I'll take it and break it down
Okay.
into individual components.
Okay.
But the things that you are referring to right now, different drugs, et cetera, that you may be coming up on is in there. But I'll break those things down. It has the Vanderbilts in there.
Oh,
It
good, because we're going
has,
to talk about that in a little bit.
Anyway,
Okay.
I'll break all that down for you.
Awesome. Okay. All right. So when we start talking about treating children for anxiety, our first priority is symptom relief. We've got to get these kids where they can be social and get past and start living a more normal life. So we've got to, and in small kids, there is a source of the problem, and we have to help identify and treat that source of the problem. Then when it comes to therapy for these kinds of kids, they really need CBT or cognitive behavioral therapy, which is individual. But the great thing about CBT is that there are family interventions, and this usually including COPE, which is creating opportunities for personal empowerment. It is not discussed in your book, so don't spend a whole lot of time on it because you probably won't be tested on it, but it's just some good information to know. Most of the time, a combination of CBT and psychopharm, which is only used if they respond to if they're not responding to therapy, is probably the best way to do it. Sometimes they just we can't either get them into CBT. There's not enough resources, but we've got to get them functioning again. Our whole goal is to enhance their coping skills and get them to where they can function again in society and around other people. Cognitive behavioral therapy targets a patient's thoughts and behaviors to improve his or her mood. So these are the three things that it does. It's behavioral activation, cognitive restructuring, and improving assertiveness and problem-solving skills. So the premise of that is thoughts influence behaviors and feelings. So we got to get their thoughts going in the right direction. Unless you don't need to think about doing cognitive behavioral therapy unless you are trained to do CBT. And I would love to see some of you guys go into the psych aspect of as a nurse practitioner provider, because we really don't have enough. But trained CBT therapists, even in this town, are very hard to find. So when we do talk about psychopharm for anxiety, and this is on table 30.1, page 425, your first line meds are going to be your SSRIs. And these are we're going to use fluoxetine or Prozac is the FDA approved for anxiety. Escitalopram is actually our first line in greater than age 12. So your Lexapro is going to be first line for your older kids, and your Prozac is going to be first line for your younger kids. However, most of the time we still start with Prozac. The interesting thing, and your book refers to this, is that fluvoxamine, which is Luvox, actually has better data as far as effectiveness against anxiety than either of the other two. I don't know why we don't use it as first line, but it's not considered first line. And then the other one that we use with anxiety is sertraline or Elavil. So now our SNRIs or our norepinephrine reuptake inhibitors like Cymbalta and Effexor, I'm not going to use those. In fact, Effexor, even though it's listed in your book, is not approved in children under the age of 18 by the FDA. So or by the AAP. So, so it's just, and that's, again, that's not in your book that it's not approved. That's just from all my other sources. Another category of first line meds is mood stabilizers, and they're listing lithium. I'm not going to prescribe lithium. If you want to prescribe lithium, I would rather a mental health professional like a psychiatrist or a trained psych mental health nurse practitioner be the one to prescribe lithium, because they have a lot of parameters that they have to, as far as monitoring for that. So like I said, a lot of times our first line meds, that's what we're going to do. So we're either going to do a Prozac, a Lexapro, a Luvox, or an Elavil.
You have Elavil on there as sertraline, but I thought Elavil was amitriptyline. Isn't sertraline Zoloft?
Okay, that was you're correct.
Okay.
Sertraline is Zoloft. Sorry, I will change my slide. That was done the other day, and I had a mental health. I actually had a bad. So thank you for correcting me. Thank you. I don't mind being corrected, and I will change that. I apologize. But you're right. It's Zoloft, not Elavil. And yes, Elavil is amitriptyline. So change that. Sorry. But it is sertraline for sure and for certain. So we go to, Burns talks about second generation antipsychotics as being a first line, risperidone and Abilify, Zyprexa and Seroquel. Again, I'm not going to prescribe those. If you feel comfortable doing that in kids, that's great. We do have a lot of kids with issues with aggression and irritability, and some of our kids with autism spectrum disorder are going to be on risperidone. I have a few kids on Abilify, not a whole lot. I had a kid today that's on Seroquel. I didn't prescribe it, but there's some real issues with the manufacturer of the medicine, and they'd gotten a letter, and so she's not sure exactly what he's taken, because there was a screw up at the factory and there's no lot numbers. They have no idea. So she's not sure exactly what's in the medicine that she's giving. So she's working with the psychiatrist, the mom is, to get the kid down off of their medicine. You can't withdraw these immediately. You have to do a very slow progression off. Now, in my AAP book, they talk about benzos. I had a pediatrician that I worked for that used to give Ativan or lorazepam for panic attacks. So they would use it not only with their SSRI for daily, but if they had a panic attack or had issues where their anxiety increased or was at a higher level, then they had PRN Ativan. And so the doc I work for now has controversy with that, but I have documented evidence with that's how it's done with some. So it makes it really hard for me in practice. So the doc I'm working with is the doc I have to answer to. So, and since I could prescribe it, but because it is a Schedule II, I have to have that wonderful being able to, oh, that's not the problem. I have that. I have to be able to electronically prescribe, and I haven't gotten that done yet. So because that would be the only thing that I would ever prescribe electronically. Okay, so moving on. That's anxiety. There's so much more that we could talk about, but this is what you're going to see, and this is how you're really going to treat it and spend time with these parents. You really want to get, as we said, get them into therapy. And if they need it, psychopharm. If you can't get them into therapy, we've got to get these kids functioning. And so that's where our psychopharm comes in, and you've got to monitor it very closely. Those kids, just like your ADHD kids, which we're going to talk about, we've got to manage them every 2 to 3 months. We've got to see them in office. We can't let them go for 6 to 8 to a year. No, we got to see them. Because what is one of our side effects potentially with kids and SSRIs? Does anybody know? Because what does SSRIs in under 18 have? What's it? It's black boxed, right? So that when you've got a child or an SSRI actually elevates your mood. So if you have suicidal ideations or suicidal tendencies, it can actually increase the energy level to the point that they can actually act out on their suicidal tendencies. So we have to be very careful in monitoring anybody that we've got on an SSRI for suicidal ideations or thoughts and tendencies. So that's one of the things you're going to ask about every time you're going to see them. Are we having any thoughts of suicide? And you're going to document that. Document. Okay. Depression is the same thing. Again, the DSM-5 is really not discussed in burns. I don't think. I didn't find it the other day when I was updating this presentation, but this is what you're looking for. We have 5 or more of the following, including you have to have a depressed mood or loss of interest or pleasure doing something that they usually found joy in. It must cause significant distress or impairment in social, occupational, or other important areas of function. It's not attributable to a physical effect of a substance or other medical condition, and not better explained by schizoaffective disorder. And there has never been a manic episode or a hypomanic episode. So that would be more consistent with bipolar disorder, okay? Which you have your ups and your downs with bipolar. Depression just in its own is separate from bipolar disorder. So what are some of our risk factors? Family or personal history of these kinds of things. And that makes as you read through it, it's going to make logical sense to you. Some of the other factors, and I guess that's what I see more in our kids, because you see depression in kids from families that you wouldn't think have issues with depression. It's a very common thing, and you can't blow it off. You've got to be serious about any kid that comes to you with either anxiety or depression. Because some of these kids, no matter what, some are going to have such very low self-esteem and very poor coping skills, or they may have attachment issues. They've lost a significant family member, and that just may bottom them out. They may not make friends easily, and they may not have much of a social structure, peer structure at school. And a lot of our overweight kids are very self-conscious, have very low self-esteem, and so they have a lot of issues with depression because they don't feel like they are loved. And so that's really sad. So you've got to look at those kinds of things. And when they come to you and they start mentioning it, that you take it seriously. Now, it's really interesting. I haven't figured out yet how they can tell if an infant is depressed, but your book lists signs and symptoms of a depressed infant. Now, can these be signs and symptoms of other issues? Of course it can. Any irritable baby is not necessarily depressed. If they're having trouble feeding, it can be related to a huge amount of things. Now, when we get down to toddlers and preschoolers, and you see issues with excessive tantrums and behavior problems and aggression and irritability and even regression, that can be a sign. That one is kind of like this toddler, preschooler doesn't know how to tell you that just things aren't right and I am so miserable and I need help. So you need to be are you going to treat that? Probably you're going to get those kids into what? You're going to get those kids into some therapy. I would not take on treating a 2, 3, or 4-year-old for depression. I would let somebody else do that, but that's me. Because I wouldn't be sure that I was doing the right thing. Those kids are going to respond better to cognitive behavioral therapy and counseling and even play therapy. So that's beyond my scope of practice. Now, our school-age children, you're going to see some of these things that are pretty common to both not only school age, but adolescents as well as adults. These are some of the same kinds of things. That nobody likes me, or they may do some acting out behaviors. And it's like, this kid, why are you doing this? These are sometimes are really smart kids. And you're just like, why are you acting out like this? Adolescents are great about the acting out and getting involved in either they just complete withdrawal or they really act out in high-risk behaviors. So you have to be really careful. You have to kind of look for that. Sometimes you have to be willing to ask. So how are you going to assess? We assess at a regular basis. That says greater than 13 because that's probably the standard age for the PHQ-9, the Patient Health Questionnaire. It is a 9-question, really quick depression screening tool. We as pediatric providers are required to do some kind of depression screening starting at age 11. So that's when we start our PHQs. The Children's Depression Rating Scale is another type of screening tool, as well as the Children's Depression Inventory and the Pediatric Symptom Checklist. Now, the Pediatric Symptom Checklist is for younger children as well, and it's a general kind of thing, but it will also pick up anxiety and depression kinds of things. It'll also pick up on others. Now, the ones above I just listed are both listed by both your Burns book and my AAP books, as far as these are depression screening tools to use in children. Listed also with Burns is the Child Behavior Checklist and the CES for depression. And then AAP does the CDI-2 and the BREC depression inventory. And I think you've probably seen the BREC if you've done any kind of study on adult depression. And then they also recommend the Mood and Feelings Questionnaire. Again, remember that you're going to be tested on what's in your book. But I also like to give you enough information to let you know what else is out there. So what are we going to do? How are we going to treat this? If it's very mild, you're going to monitor it. But I'm going to probably send them, this is what your book says, active support and monitoring. They usually say come back every week or so to revisit. Most of the time, parents and families don't have time to do this. I'm probably going to get them into counseling services. That's the best thing in the world that we can do for them, is to get them established with a counselor. If they have moderate to severe depression, usually requires some psychopharm meds. And sometimes there's crisis intervention. And we're very blessed here in Bowling Green, Warren County, in that we have a crisis intervention center over on Chestnut Street. So if we've got a kid who has thinking about suicide or talking about harming themselves or others, or acting out in ways that can cause harm, we have the parents take them immediately to the crisis intervention center. Yeah. Okay. And then, yeah, we're gonna get them in, if they haven't already, we're gonna get them in with a mental health consultant. Antidepressants work well alone in the adolescent age group, but in our school age group, they really need cognitive behavioral therapy or interpersonal therapy when possible and it's appropriate. As we've already talked about, SSRIs should be decided based on effectiveness and safety. As we already talked about, Prozac or fluoxetine is our drug of choice, and we're going to monitor that. This says every 6 to 8 weeks. I'm going to monitor it once they're established and they're doing well. I'm going to monitor it every 3 months. Until that point in time, I'm going to see them once a month. IPTA is a type of, it's not necessarily mentioned in your book, so I'm going to move through. It's a way of helping, especially our older kids, deal with their problems. So it targets their problems in both interpersonal functioning and in their mood. So they identify the personal problem area, they improve their problem solving skills, and then they modify their communication patterns. So that's how that works. Again, you need to be trained in that to be able to do that. What are we going to do? We've talked about this a little bit. We're going to watch the first couple of months. We may need to increase the dose. We may need to decrease the dose. We're going to look for all those symptoms that we've already talked about, the depressive symptoms, the risk for suicide. And when you start a kid on an SSRI, you have to have that conversation, especially if it's an adolescent, with both the adolescent and the parent, that this can increase the risk for suicide. So if your feelings change, if you feel like you may want to harm yourself or other, it's really important that you've got to tell that adult. And parents need to be on the watch. That is just part of being a good provider, is making sure that you have talked about that and that you document that. And then adherence to treatment and talking about their stressors. Again, the book recommends weekly face-to-face contact during the first 4 weeks. Most of our parents are not going to come in every week. They're not going to pull kids out of school to come in every week. And then they say bi-weekly visits. And at 12 weeks, then they can go every 3 months. Now, if you were to get a test question, you need to know that's what is recommended. Likelihood of that happening clinically, unless it's just really bad, is probably not going to happen. So, of course, your clinical worsening is your suicidal or unusual changes in behavior. One of the things that, I don't know if you all have been taught about this yet or not, if you've had any other psych kind of classes or any other psych information, is that when you start somebody on a serotonin, let's see, SS. Yeah. What's the first? Serotonin. Yeah. The second one is SNRI, is serotonin NUR. Yeah. Okay. We're both having brain farts over here today. So anytime you start an SSRI, you have to worry about serotonin syndrome. Okay. Because this is a type of reaction that is caused by the medication. So these are some of your symptoms: confusion, agitation, dilated pupils. You think that they've actually on something else. Headache, blood pressure changes, nausea, vomiting, diarrhea. And if this occurs, these people, they need to get to the ER. They need to be seen. They need to be in the hospital because there's intervention that needs to be done. So be aware of the potential for serotonin syndrome. And especially, especially if you've got polypharm when it comes to psych meds, serotonin syndrome becomes a much likely potential that you really need to watch for. Okay. All right. That's the end of that one. Any questions so far on anxiety, depression? Have I bored you to tears so far? You want to come get the next one up?
Which one are you doing?
ADHD. So get your ADHD, pull your ADHD slideshow up.
Got too many things opened.